extreme pleasure to introduce our next candidate for the faculty position that we're considering folks for in PFRH, Erika Thompson. Erika Thompson is currently a postdoctoral fellow at the Department of Community and Family Health at the University of South Florida. She earned her doctorate there in 2015. And she also earned graduate certificates in biostatistics and in maternal and child health epidemiology. So her research, which focuses on women's decision-making about their reproductive health choices, has resulted in over 28 peer-reviewed publications, 10 of which are first authored. That's quite an accomplishment for somebody who just graduated in 2015. But as we've discovered in talking with her, and the committee has learned, she's not working from a cave in USF. She's actually really involved in the community and public health. Her productivity is fueled by a depth of understanding of theories, social, cognitive, behavioral, public health theories, as well as a life course perspective. And that is that perspective and that depth of understanding she brings together with quantitative methods, how to describe the phenomena, how big the problem is or the issue is, as well as moving on to answering questions about why. Why do we see the disparities and the disconnects that are so common in women's reproductive health? So her focus has really been on women's decision-making, how they come to decide whether to get the HPV vaccine or how to protect themselves against Zika, those kinds of things. And she uses mixed methods as her general approach, so that many of her papers are multiple perspectives on the same type of issue, seen from a different lens. Very rich and thoughtful. She currently works on several HPV and reproductive health grants, and in the past year has obtained 2 small grants of her own as a postdoc. One is a formative study to examine reproductive decision-making in the context of Zika among reproductive age men and women in Florida. The other was awarded by the Association of Teachers of Maternal and Child Health to develop innovative methods in teaching MCH. She's taught public health perspectives on women's health for the past 4 years at USF, and has also co-taught several other women's health courses, as well as the core epidemiology course at USF. Her teaching is based in experiential learning, bringing students directly into all aspects of research and the research process. As is true for many of you, her research brings her into sensitive and controversial subjects with significant policy relevance. She has directly confronted these inherent challenges in working in reproductive health. You may have seen a recent publication of hers in the MCH Journal called Rethinking Preconception Care, which really examines the values of and the value of focusing on the hypothetical child that a woman or a young woman or adolescent might have in order to encourage her to be healthy. And she also has a very thoughtful paper on the feminization of the HPV vaccine that really helps us think about how we've maybe missed an opportunity to promote better HPV vaccinations. So many thoughtful and thought-provoking articles, and I know that you'll find her talk interesting. I ask you to welcome Erika Thompson.
Thank you for that introduction. I'm very excited to be speaking with you all today concerning women's reproductive, ongoing, and emerging issues. As you know, I'm Erika Thompson, and before I get started, I want to start with some of my background so you know where I'm coming from, although Dr. Riley did a much better introduction than I'm going to do. I come from the University of Florida, where I received my master's degree in epidemiology, and then continued my training in public health with a focus on epidemiological methods and social behavioral approaches. And while at USF, I was fortunate to receive specialized training in maternal and child health through our Center of Excellence in the Maternal and Child Health Epidemiology Program, as well as MCH leadership. Since completing my degree, I've continued as a postdoctoral fellow at the University of South Florida and have specifically collaborated with our Child Center, which is named after a former governor in the state of Florida. It's not the Child Center, common mistake. And the focus of this group is to bring together an interdisciplinary synergy of maternal and child health researchers. And my primary role in this center is not only to be in the leadership, but also help shepherd the women's health group, where we bring together collaborators to work on pressing women's health issues. So I'll be presenting some of the projects that have come from that program as well. So in today's presentation, I'll walk you through some of the previous research that I've done related to HPV vaccination, describe some of the current research I've been working on while a postdoctoral fellow, describe some of the research and training opportunities that I've developed while at USF, and then finish off with some next steps moving forward. So we'll start first with HPV vaccine decision-making. So human papillomavirus, or HPV, is this virus up here. It's the most common and incident sexually transmitted infection in the United States. It can cause genital warts, which can cause significant morbidity. But what gives us most concern is its association in being a causal agent for cancers, including cervical cancer, anogenital cancers, and oropharyngeal cancers. Altogether, about 30,000 cancers a year are attributable to this virus. That means there's significant morbidity and mortality associated with HPV. However, as of 2006, we've had prevention available to us through the HPV vaccine. In 2006, it was primarily targeted toward adolescent females. And since that time, we've seen changes in next generation vaccines, changes in dosing, and changes in guidelines. So I just want to quickly review what those current recommendations are. Today, there are 3 vaccines on the market, the bivalent vaccine, and most commonly thought of the quadrivalent and nonavalent. The nonavalent protects against 9 types of HPV, including low risk causing genital warts and high risk or oncogenic risk causing cancer. The nonavalent came out in 2015 and is now shifting in to be our standard of practice. Currently, the vaccine is targeted toward 11 to 12-year-old adolescents. However, not all adolescents receive the vaccine at this time, and that's why we have catch-up vaccination available. For males, this can be between the ages of 13 to 21, and it gets a little complicated at 22 to 26, is particularly focused on high-risk men, so men who have sex with men or immunocompromised men. In contrast, females have a consistent recommendation, and that's catch-up vaccination between 13 to 26. And the group I'm going to focus on today are those young adult women who fall in the 18 to 26-year-old category. And you might be wondering, well, why is this an important group to consider? Unfortunately, HPV vaccination rates remain suboptimal in the United States. Only about 60% of girls have received at least 1 dose of the vaccine, where the targets should be closer to 80%. That means a significant proportion of adolescents will transition into young adulthood, still needing that prevention opportunity. And what makes this a unique period in the life course is that it's a time of autonomous decision-making during emerging adulthood, where a young adult can still benefit from this particular vaccine, and women in particular tend to have higher healthcare utilization during this time period. So upon examining this particular group, rates of HPV vaccine uptake among young adult women are also low, with only about 40% receiving at least 1 dose. And the barriers and facilitators to vaccination have been widely reported. And in conducting a systematic review, I found that these range across the socio-ecological model, including things at the individual, such as knowledge or attitudes, beliefs, the interpersonal level, such as provider recommendation, and range all the way up to the societal level, such as our vaccine culture in the United States. But what I wanted to know are, who are the groups who are consistently not getting vaccinated for HPV? And one group stood out in particular, and those were women who were in relationships were less likely to receive the vaccine. And repeatedly in the epidemiological literature, women who were in a relationship were more likely to be unvaccinated compared to their counterparts. Now, the authors of these studies hypothesized, well, this could perhaps be due to perceptions of monogamy or how women feel about their relationship. Yet at that time, no research had been conducted to understand why that disparity was occurring. So you might be sitting there wondering, okay, well, is there really a risk for HPV that these women need to be concerned about? Well, think about the average lifetime risk for HPV for a woman with only one sexual partner is 85%. As I said, it's the most common sexually transmitted infection. Additionally, if we look at the sexual profile of women, the median number of lifetime sexual partners is about 4 for a woman in the United States. This means that the risk isn't as low as we might consider, especially in the United States, and even for a woman practicing monogamy or serial monogamy. Given these guidelines for catch-up vaccination and this disparity in terms of HPV vaccination among women in relationships, I wanted to understand what is relationship status's influence on HPV vaccine decision-making among young adult women. So I'm going to walk you through a 3-part study, a mixed method study. The first research question asked, are married women less likely to be interested in the vaccine? So we're seeing this disparity, maybe they're just not interested in getting it. Secondly, is there an association between relationship status and the reasons women have for not wanting the vaccine? And both of these parts come from the quantitative phase. And then in the qualitative phase, what influence does relationship status have on HPV vaccine decision-making among young adult women? So I'll start first with research question 1. Are the married women less likely to be interested in receiving the vaccine compared to non-married women? And for this phase of the study, I utilized the National Health Interview Survey from 2010, which assessed specific questions related to HPV vaccine decision-making at that time, and is a nationally representative survey. I focused specifically on unvaccinated 18 to 26-year-old women, which had a sample size of about 1,400 women. And I utilized survey-weighted logistic regression in SAS and converted to prevalence ratios since my outcome variable wasn't a rare variable and needed to account for that higher prevalence. And that outcome variable was interest in the vaccine, dichotomized as yes or no. The primary predictor was relationship status, and the covariates adjusted for in the final model came from the literature and were a combination of sociodemographic characteristics as well as healthcare utilization. So I'm going to jump right into the results, and this table indicates the survey-weighted percent of women who were interested in receiving the vaccine by relationship status category. So as you can see, married women, about a quarter were interested in receiving the vaccine, compared to about a third for the other relationship status categories. And looking at the adjusted prevalence ratios, adjusting for those other factors, women who were living with a partner or who were never married were significantly more likely to be interested in getting the vaccine compared to married women. Thus answering the first research question. Married women were less interested in receiving the vaccine. This led then into the second research question. Well, if they're uninterested, what are the reasons why are they uninterested? And is there a difference by relationship status? So again, using the same data set, but further restricting to women who are unvaccinated and now uninterested in getting the vaccine. I also excluded women who are in that widowed, divorced, separated category because at this age range, there weren't many women in that category, and that had a lot of 0 cell sizes for that particular group. So this had an analytic sample size of 940 women. I utilized survey-weighted frequencies and a Rao-Scott chi-square test to assess the relationship between 2 variables, and that was relationship status and then primary reasons for non-vaccination. And the women in the survey were asked, what's your main reason for not wanting to get the vaccine? And there were over 12 response options, and I focused on the top 4 response categories, as you can see here on this screen. But the top 4 were, I don't know enough about it, I don't need it, I don't need the vaccine, the doctor didn't recommend it, I don't know enough about it, and worried about safety for the vaccine. The remaining response categories were aggregated into other, and these comprise things such as I'm not sexually active, I already have HPV, my family member said I shouldn't get it, and these were combined into the other category. So looking at the survey-weighted percentages of women reporting these reasons, women most cited that they did not need the vaccine, with about 47%. This was followed by other, and then don't know enough. Women living with a partner had a similar distribution, but more shifted toward that right-hand side of worried about vaccine safety and other. And then never married women followed a similar distribution. And overall, there was a significant association between these two variables. But upon looking at the survey-weighted proportions and 95% confidence intervals, women who were married were more likely to say they did not need the vaccine compared to never married women. Now, there are limitations to this analysis, including these are self-reported data, especially for the survey limiting variable of vaccination status that was not provider verified. Additionally, there's the potential for non-response bias, as there was a 60% response rate for this particular survey. And finally, small frequencies for some of the reasons for non-vaccination, which resulted in an aggregation of that response group. But if we think about what we know so far based on these first two research questions, married women were less likely to be interested in the vaccine and more likely to say that they did not need it. But this led to the question, well, now we need to understand why these differences are occurring, which leads into the second phase of this study and the third research question. What influence does relationship status have on HPV vaccine decision-making among young adult women? And for this phase, I focused on young adult college women who were between the ages of 18 to 26, and I focused on women who either had never received the vaccine or received the first dose in the last 6 months, so I could compare perspectives between vaccinated and unvaccinated women. Additionally, all participants spoke English and provided informed consent. In addition to that general inclusion criteria, I utilized a stratified sampling approach, again by vaccination status, unvaccinated or recently vaccinated, but also by relationship status. And I had the opportunity to use finer categorizations than were available on that national survey and more applicable to a young adult woman. All of the participants were able to self-identify what relationship status category they fell in. And upon doing the analysis, these top two groups, married or living with a partner, as well as long-term monogamous relationship, were more similar than different and were eventually aggregated together. Overall, there were at least 6 women per cell, with a total sample size of 50 women. So I conducted in-depth interviews via telephone, and these lasted about 30-45 minutes, and the audio recordings were transcribed and verbatim. And from there, I applied a priori deductive codes based on the information, motivation, and behavioral skills model, which was the overarching framework for this phase of the research and can be saved for another day. But that was the overarching framework for this particular study. Along with the second coder, who coded 10% of the interviews with me, we had an inter-rater reliability of 88%, indicating strong agreement. And from there, I conducted a comparative thematic analysis across those different stratifications. So first looking at, to understand how does relationship status influence a woman's decision to get the vaccine, I asked women who received the vaccine what role their relationship status had in that particular decision. And interestingly, relationship status did not have an influence for them. It was not on their radar in terms of HPV vaccination. In fact, there were these other more influential cues to action that helped them decide to get the vaccine. And some of this was risk realization, such as having an abnormal PAP or knowing someone with an abnormal PAP. It also included a doctor recommendation, as this woman stated. It wasn't her relationship status, her doctor said she should have it. So that's what she felt was most important. Additionally, women stated that it was a personal decision for them. So it wasn't necessarily any of these outside sources influencing them. It was good for their health and they decided they wanted it. So overall, among the vaccinated women, relationship status was not a factor in terms of the decision to get the vaccine. But we see a slightly different story when we look at the unvaccinated women. Particularly women who were in a relationship said that because they were monogamous or didn't have many sexual partners, they didn't need the vaccine. If their relationship changed and they became single, then they might consider getting it, but right now they were protected based on their relationship. As this one woman stated, "Oh, we've been together, we're fine, we don't have it," although I know that's not always the case. Now, the single and dating women had a slightly different response. Relationship status really wasn't on their radar in terms of their decision, but actually would be less inclined to get the vaccine if they entered in that long-term monogamous relationship status category, so kind of shifting into the other group. And then the single-only women stated they also didn't need the vaccine because they weren't sexually active. Many of these women self-reported as being abstinent until marriage, as this participant states, so she doesn't need the vaccine. And if she ends up getting married and her partner has HPV, then she'll get the vaccine. But if their relationship status, and I can see some shrugging heads in that response, and I feel the same way. If they entered a relationship and eventually got married, then they'd consider getting vaccinated. So as you can see, a lot of this has to do with how these women are perceiving their risk and their perceived need for vaccination. So looking at the whole sample for risk perceptions for HPV, overall women who were in a relationship said, again, their risk for HPV was low because they were monogamous. Women who were single and dating had a more varied risk perception, again, depending upon their personal circumstances because they were more heterogeneous. And then the single-only women, again, stated they were at low risk because they weren't sexually active or because of their sexual history. Now, there are limitations to this particular phase of the study, and I utilized a convenient sample on a college campus. However, this difference in relationship status and vaccine uptake has also been observed among college samples. Additionally, there's the potential for subjectivity in qualitative research, but using a second coder as well as reflexivity throughout the analysis process help mitigate some of those issues. And finally, there's also the potential in terms of social desirability bias as we're talking about sensitive topics such as monogamy and sexuality. So this comes back to the main question. Why are women in relationships not getting vaccinated for HPV? Well, it appears that current relationship status may be acting as a barrier to vaccination. Women in those relationships are less interested in the vaccine, they say they don't need it, and in the qualitative phase said because of their monogamy or their number of sexual partners, they're not at risk and they don't need the vaccine. So the implications of this work mean that while relationship status may be a barrier to vaccination, what we found among the vaccinated women is that there are these other cues to action that help them realize their risk or their need for the vaccine. So perhaps acting on these potential facilitators can improve HPV vaccination among this group. And tailored health messages regarding these HPV risk misperceptions could address this issue. And this leads into some of my next steps, including generalizing the findings from that qualitative phase to a larger, more diverse sample of women who necessarily don't come from a college sample to see if those same findings are reported regarding relationship status and risk perceptions. Additionally, I'd like to include healthcare providers since these are key agents in terms of HPV vaccine delivery in the United States. We have a provider-based model, and particularly OBGYNs who aren't our traditional vaccinators. Bringing these two types of research together can help inform those tailored health messages and eventually interventions to promote HPV vaccine uptake. So that was a quick overview of some of the research that I've done related to HPV, and I could go on and on about HPV vaccination, but I wanted to shift to some of the current research I've been doing during my postdoctoral fellowship. And upon starting my fellowship, I really wanted to focus on contraception and pregnancy intention as it applies to women's health. And I started my fellowship in 2016, and something else happened around that time that you all might be aware of, and it's this big mosquito here. Zika virus came to international and national attention as it spread through South and Central America and then into the United States. And this table at the bottom indicates that Florida had the bulk of those cases, both locally acquired and travel-associated cases. And while Zika is primarily mosquito-borne, it can also be transmitted sexually as well as a laboratory exposure as well. And it tends to be an asymptomatic disease. However, we're concerned as a public health community and maternal and child health in particular due to the negative outcomes associated with Zika, particularly microcephaly. And the recent data coming from the CDC Zika pregnancy registry indicate that 1 in 10 of women who had a confirmed Zika infection pregnancy, it resulted in a fetus or baby with a Zika-related birth defect. And this can have long-lasting implications in terms of morbidity, economic, and social consequences. Another unique feature about Zika virus is the fact that it can be sexually transmitted. And this was confirmed between April and July of 2016. We saw a number of reports saying, oh, it's male transmitted, and then female transmitted, and then corresponding guidelines on how to prevent transmission. And while the focus has primarily been on pregnant women, as it should be, given these negative outcomes, another group that we need to consider are women or couples who are not desiring pregnancy and are not pregnant. And these couples, as recommended by the CDC, should be using the most effective contraceptive methods as well as barrier methods to reduce their risk of Zika. And all of this is due to the fact that we want to prevent Zika-related birth defects. And researchers here at this institution appropriately stated that we have a prevention approach. It's available. Family planning. These technology and tools are already available and can be used. In fact, a simulation study indicated that improved access to contraception alone could more effectively reduce Zika-related microcephaly births compared to a hypothetical vaccine with adequate uptake. So we need to focus our efforts on the tools and resources that already exist for this particular health issue. Yet in Florida, we definitely have an unmet need for this type of prevention, where 59% of pregnancies are unintended, higher than the national average, and a quarter of the women in Florida who are at risk for an unintended pregnancy were using no form of contraception. What makes this even more complicated is the fact that the periconceptional period, or the time right before a woman gets pregnant and right after, is the highest risk time for these birth defects, a time when a woman doesn't know she's pregnant, especially with a virus that is often asymptomatic. So as an approach to address part of this need can come through the process of health literacy. And this is a public health approach to health literacy, which examines an individual's ability to make an informed health decision. And I'm applying it here in the context of reproductive decision-making in terms of contraceptive use, as well as pregnancy planning. And health literacy has been previously applied to a range of topics, including pap testing and breastfeeding and multivitamin use. However, I believe it's particularly important for this emerging health issue since we're rapidly seeing changes in these guidelines and communications about prevention. So this led to a formative study I conducted and received funding for to elicit the health literacy related factors for reproductive decision making in the context of Zika among non-pregnant reproductive age men and women in Florida. And my target population were those reproductive age men and women in Florida, and to be included, a person had to be sexually active, live in Florida, and be of childbearing age. I did exclude people who were currently pregnant or had a partner who is currently pregnant. And these participants were recruited using social media as well as campus locations between September and December of 2016, so after those guidelines had come out from the CDC regarding sexual transmission. I conducted in-depth interviews with 40 participants to assess their attitudes and beliefs regarding Zika and reproductive health, and utilized a priori codes based on that health literacy model I'm going to tell you a little bit more about in a moment. And along with a graduate student who had a very particular interest in learning qualitative research, she helped code 10% of the interviews, and we achieved a strong reliability. And from there, I conducted thematic analysis. Additionally, participants completed an online survey through Qualtrics that assessed their demographics, contraceptive practices, Zika knowledge, and willingness to change behavior in the context of Zika. So the sample included 40 participants, majority of which were female, 85%, and the majority of participants were white, non-Hispanic, and in some form of relationship, either married or a committed relationship. Additionally, in looking at the contraceptive practices at last sex, the majority of participants used a moderate or low effectiveness or no effectiveness contraceptive method, and most did not use a condom at last sex. So coming back to that idea of health literacy that I mentioned earlier, I've been applying a framework developed by the European Union Consortium on Health Literacy, where they systematically looked at all of the definitions and models of health literacy and developed an integrated framework. And at the core of this model is the constructs of access, understand, appraise, and apply, and how a person goes about making that informed decision. I'm going to describe each of these constructs as we go through the results. And we'll start first with access. So access refers to how someone gets information or where they get it from. And participants were asked, well, where do you get your information regarding to Zika and reproductive health? And luckily, they were going to a very reliable source, including the CDC webpage. Understand refers to how a person comprehends or understands a health issue. And for Zika, these participants recognized that Zika was sexually transmitted, mosquito transmitted, and linked to birth defects. However, participants were more informed about mosquito prevention, stating I need to wear bug spray or long sleeves, compared to sexual transmission, where they more ambiguously stated things like safe sex or just be safe. They had a more difficulty articulating condom use should be part of that conversation. Now, appraise in the health literacy framework refers to how a person evaluates or judges that information and how it's relevant to their personal circumstances. So part of that process is seeing how confident are these participants at engaging in these prevention behaviors that they reported. Overall, the participants said that they were more confident in preventing sexual transmission, even though they had lower knowledge about it, than mosquito transmission. And you're probably wondering the same thing I was wondering. Why? Why is this the case? Well, participants stated that because we live in Florida, mosquitoes are unavoidable. As this one participant stated, you can never entirely prevent a disease transferred by a tiny bug in Florida. They're everywhere. It's impossible. So there was this fatalistic attitude regarding mosquito prevention practices in Florida. And in contrast, participants were very confident in preventing sexual transmission because they said they're monogamous. And this was reiterated by many of the participants saying, well, a couple that's monogamous, they don't need to take extra protection. Although that's not the case for Zika. Monogamy is not protective for Zika. So this was an interesting reversal in terms of their understanding and then appraisal of the situation. And then finally, in terms of apply, that's how a person uses information, and that could be a prevention behavior or talking to someone. And in the context of Zika, these participants were not changing any prevention behaviors for mosquito prevention or bug spray or condom use or overall no behavior change. And when asked if they were willing to change their behavior, most participants said no. If Zika was in my area, I would not change my birth control or my sexual behavior in response to Zika. So there are some limitations to this formative research study, and that is it was a convenient sample with a range of counties represented in Florida, all of which have had cases of Zika represented, but only 2 participants came from an area of local transmission. Additionally, there was a smaller proportion of males as I was wanting to oversample females in this study. Again, there's the potential for subjectivity in qualitative research, but having a second coder helped improve the reliability of the coding scheme, and also social desirability bias, again, talking about more sensitive topics. So coming back to that health literacy framework, these participants reported adequate access and understanding of health information. They knew what Zika was, they knew what it caused, they knew how to prevent it for the most part. However, the difficulty came in that appraisal phase, where their cognitions weren't matching what they were actually thinking or doing. In terms of appraisal, participants said, well, I have this mosquitoes are everywhere mentality, there's nothing I can really do, a fatalistic approach. And then specifically for sexual transmission, that misbelief that monogamy was protecting them against sexual transmission resulted in their applied behaviors. So the implications of this research is that while monogamy is a protective factor for sexually transmitted diseases, we have a success in public health, we've disseminated that message well, it is not a protective factor for Zika and sexual transmission. Therefore, the health messages regarding this particular emerging health issue need to integrate this misperception. And one approach to facilitate this process is actually on its way. I've been a co-investigator for a USF Health internal grant specifically earmarked towards Zika prevention. And we're going to examine OBGYN providers, reproductive counseling in the context of Zika to see how well are they implementing the guidelines from CDC and what factors facilitate this implementation using an implementation science framework. So those results will be coming hopefully in the next few months. So as I mentioned earlier, part of my postdoc was to focus on contraception, and while it was integrated into that Zika research, I have continued to pursue that as an area of training and research. And I just want to highlight a few studies that I've done along the way. And overall, there are definite contraception needs in the United States, as 45% of pregnancies are unintended, and this risk is largely attributed to non-use or use of less effective forms of contraception. However, we have the tools available, including long-acting reversible contraception, or LARC, and these include the contraceptive implant and intrauterine device. And these can last anywhere between 3 to 10 years based on the method, and kind of are that place it and forget about it mentality because it doesn't require user error once inserted. Additionally, it is reversible, so once removed, a woman can resume her fertility. Because of the benefits of LARC, it's endorsed by the American College of Obstetricians and Gynecologists as a first-choice contraceptive method, even among adolescents and nulliparous women. Additionally, it's been recommended as an immediate postpartum method, so to be placed after a woman delivers and before she's discharged from the hospital, a time where we definitely know she's not pregnant. Unfortunately, rates of uptake are not as high, with only about 11 to 12% of contraceptive users using a LARC method, and the majority of which use the IUD. So I just want to give a brief snapshot of 3 studies that I've conducted related to LARCs, first starting with condom and LARC use. Now, while LARC is very effective at reducing unintended pregnancy, it does not provide STI prevention, which is of particular concern among young adults, especially college students, where young adulthood is where the bulk of the new infections we see occurring. So I wanted to compare, well, how does dual use of a condom among a LARC user compared to other contraceptive users? And what are the factors associated with condom use among a LARC user, particularly among college women using the National College Health Assessment data from 2012 to 2013? And what I found were LARC users were less likely to use condoms, only about 24%, compared to other contraceptive groups. Additionally, dual condom use among women who were using LARC was lower among women in a relationship and women with only one sexual partner compared to having many sexual partners. So this describes that there are groups of women who are using LARC on college campuses who may need the added protection of condoms when engaging in sex, particularly among this high-risk population. The second study deals more with dissatisfaction with intrauterine devices. So it builds on some of the work conducted by a researcher here at this institution, where she examined discontinuation and dissatisfaction with contraceptive methods using 2002 data from the National Survey of Family Growth. And at the time, the survey did not have a measure related to reasons for dissatisfaction with IUDs. And as we saw on the previous slide, the bulk of LARC users are IUD users. So this was an opportunity to assess reasons for dissatisfaction among women discontinuing IUDs using the National Survey of Family Growth from 2011 to 2013. And the key findings were that among IUD users, 28% discontinued due to dissatisfaction with that method, with the primary reason for dissatisfaction being side effects such as abdominal pain, bleeding, and infection. And the benefit of conducting this research is that while we see this among a lot of clinic samples, this is a generalizable representative sample describing reasons why these women are dissatisfied and could translate into anticipatory guidance providers may provide women who start using one of these methods. And finally, postpartum LARC as an issue. I've been fortunate to work with a quality improvement initiative in the state of Florida where we're trying to implement postpartum LARC in hospitals. And I've been charged with being part of the education team for patients and providers to describe what LARC is and what the benefits are and give women the contraceptive choice. But upon starting this, we realized, well, we need to go to the literature and understand what are the factors and what do patients and providers understand about postpartum LARC, since it is a more sensitive issue, since it's placing contraception right after a woman has a baby. So I conducted a systematic review using the PRISMA guidelines and eventually drilled down to 8 articles included. And that in and of itself indicates there's not a lot out there in terms of patient and provider perspectives regarding postpartum LARC. And most of the studies focused on providers, mainly if providers thought it was safe. And that was the main focus of those studies. Additionally, there was limited discussion of postpartum implants, where the most focused on IUDs. So the findings from this review will help inform some of the educational materials we're developing and messages for healthcare providers. In addition, we'll be collecting some formative data from the consumers to get their perspective on the educational material so that it's consumer informed. I'd now like to transition a bit to talk about how some of this research has informed some of the training opportunities I've developed while at USF. And one in particular deals with mentoring and secondary data. The dean of our college, Dr. Donna Peterson, emphasizes that publishing is the coin of the realm, and our doctoral students should leave with a publication under their belt, if not one, maybe more. So she wanted to integrate more manuscript writing opportunities into doctoral training, and along with my colleague, Dr. Ellen Daly, we developed secondary data groups where we recruited doctoral students based on their interest level and allowed them to develop independent research projects. And from there in these groups, doctoral students aren't only the lead author on a paper, they're co-authors on their colleague's paper. And as part of this strategy, I've developed a number of worksheets and tools for the students and been primarily the technical assistance for these projects in terms of research question development, variable selection, manuscript development, taking away that curtain behind what is publishing for these students. And so far, we've had 4 groups with about 3 to 4 students each on a range of topics, but primarily focused on sexual and reproductive health and maternal and child health. And to give you a snapshot of our process data so far, we've generated over 16 research questions. Again, these are coming directly from the students from 4 different databases. This has resulted in a number of conference abstracts for these students, locally and nationally, many of which are coming up at the upcoming APHA. And the ultimate outcome, peer-reviewed publication, has resulted in 5 publications, either accepted or published, and then 1 under review, and many more in the pipeline. So far this has been a successful strategy, and we've been integrating feedback from students along the way to monitor and adjust how this process is going, and we'll be expanding to 3 additional groups this coming fall. A second training opportunity that I've developed while at USF comes from funding from the Association of Teachers of Maternal and Child Health, or ATMACH. And I received an Innovative Teaching Award to develop a piece of curriculum related to examining changes in prevention guidelines in maternal and child health. We often see changes in evidence-based recommendations from the prevention task force, such as mammography or pap testing or pelvic exams. However, we wanted students to understand, well, why do these guidelines change? What is the evidence that supports it? And how is this implemented into practice? So as part of this teaching activity, they learn about that background, but then go out in the field and interview persons from that target population where the guideline changed to understand their health literacy regarding these issues. So as part of this activity, I've developed a number of instructional resources which anyone can use and put into their own classroom, including a lesson plan, narrated and unnarrated presentation. And if you're bored one day, you can listen to the 30-minute narrated presentation and get CPH credits as a bonus. It also includes assignment and grading rubrics and sample submissions. And as part of this collaboration with ATMACH, I've expanded my role to be chair of the Education and Mentoring Committee, where I can hopefully offer more of these resources to other members of ATMACH, not only in academia, but in the practice field as well. So that leads me now to some of the next steps in terms of research. And I've highlighted a few studies in particular in topic areas, all of which blend with the sexual and reproductive health and maternal and child health research conducted here. First, HPV vaccine decision-making. I plan to continue and follow up research with young adult women and OBGYNs to figure out ways that we can integrate those messages regarding risk misperceptions. Additionally, I'm working with colleagues across the nation looking at HPV vaccination generally among young adults using a social determinants of health framework. And I'm in the process of resubmitting a maternal and child health bureau focused on HPV vaccine decision-making among parents of adolescents. Secondly, continuing with Zika and reproductive health, continuing that grant focused on OBGYNs, reproductive counseling practices and behaviors, and implementation of guidelines. I've also collected some data among college students examining their Zika prevention practices and behaviors to see how they've responded in terms of the crisis in Florida. And finally, I plan to continue and focus on contraceptive use as a research priority, looking specifically at LARC decision making. I hope to develop a grant proposal related to that area and continue with our quality improvement initiative in the state of Florida, since we're still in the infancy of that project and we'll be rolling out implementation in the next year and a half. And to complement the findings, not only from the formative data we collect from that project, I will also be conducting an analysis using PRAMS data to examine postpartum contraceptive practices and behaviors. So with that, I thank you all for your attention this afternoon. It was a pleasure sharing my research with all of you, and I'll take any questions you may have.
Enjoy that. Lots of things to think about. Dan?
Very good. You talked about the U.S. and Florida. Could you talk about the comparison, say, of LARC or of dual method use with maybe Canada or Europe? How do we fit with places like this?
That's a very interesting perspective. So how does the United States compare to other nations, especially developed nations like Canada? Unfortunately, most of my research is focused on the United States, and I can't comment on their practices. I do know that we in the United States have a different perspective in terms of sexuality and contraceptive use, and definitely a more hostile environment in terms of women's reproductive health. So I unfortunately can't answer that particular question, but it's something I will explore in the future. Thank you.
So I do know that LARC use is higher in Europe and Canada, much higher than in the US. But my question was, when you looked at women who were now in a relationship and how that affected whether or not they got the vaccine, were you able to separate, so were they in a relationship when they got the vaccine versus?
Yes, it was their vaccination status at the time of the, or it was their relationship status at the time of vaccination was how they were sampled. And that's why I used that brief window of 6 months to get a recent vaccine. Because if they were in a long-term relationship, hopefully that included 6 months ago.
Yes. Why don't we introduce ourselves when we ask our questions?
Sure. I'm back. So my question really relates to extending the research that you've done looking at relationship status. Because you're talking about girls who got, or young women who've gotten to 18 to 26. That means their families didn't take up the vaccine.
Right.
So I wondered about, and we know from sort of anthropological studies that in fact, much of the decision making about health is made within the context of families and social networks, and not just the context of the relationship with, or your heterosexual relationship. So I wondered about the extent to which you thought about extending your research to actually look at sort of that family influences, because clearly there are some women, particularly single women, where it strikes me that family and family views may be one of the reasons why they haven't gotten the vaccine. So I wonder if you thought about that.
Thank you. That's an excellent point regarding families' perspectives on HPV vaccination. And part of that study, using that information, motivation, behavioral skills model, allowed me to assess what are those social influences for HPV vaccination. One, the main focus being on that relationship status, but I also explored what did family members say. And what you said is on point with that. Women who were in the single-only relationship more often cited their parents and their culture and beliefs in terms of abstinence until marriage as being critical in that decision-making process. And a piece that I've written that's currently under review talks about, the quote out of it is, "My mom said it wasn't important." And we know that moms are so important in this particular vaccine, and maybe saying, well, my adolescent girl is not sexually active, she doesn't need this vaccine. So I know the familial unit is very integral to adolescent vaccination for sure, and definitely has a presence in young adult women as well.
Hi, we met earlier, and I was actually just thinking we totally should
to talk about some of the work we do with the health department around LARC. So based on some of the work we've done, I'm wondering if you could talk a little bit about just the diversity of experiences with LARC. So a lot of the work we do here is with like young African American young women, and I noticed that in some of your qualitative samples there are very few women of color. So if you can talk a little bit about how you might think about your results in context of like race and poverty and other things that may also be influencing LARC usage.
That's an excellent point. So yes, particularly for LARC, so that the perceptions of LARC and postpartum LARC in particular, in doing this quality improvement initiative, we've been trying to get feedback from our community partners who maybe represent groups of people in especially Hillsborough County. We have the Healthy Start initiative that reaches at-risk groups, as well as the name is blanking on me, but we have another group that aimed at reducing infant mortality. And these opinion leaders have been very vocal in describing what concerns particular minority groups might have, or communities in general regarding the practice of postpartum LARC. And that's part of the reason why we went to the literature. It's very sparse regarding that particular issue, but we'll also be doing formative data collection with pregnant women and postpartum women to try to get a variety of experiences to make sure that we're inclusive in our description of LARC, and also emphasizing that it's a choice. So we're not prescribing LARC for everyone. It's not something you have to have. Here's LARC with an option of all contraceptive methods. And you, as the decision-making agent, get to pick what's right for you.
I wanted to ask a question about the model, the health literacy model, which is access, knowledge, and appraisal. Right? The appraisal part, you seem to suggest from your qualitative work that the women did understand the risks of Zika, but then in the appraisal part, it really contradicted their understanding, right? So
Right.
I wonder what you think about that, and maybe revisiting the understanding issue. How you might search that question.
So your comment about the health literacy framework has been bugging me for a while, particularly in that appraisal process. So while access and understand refers to that more cognitive process of decision making, the way that it's set up in this health literacy framework is very cognitive as well in terms of appraisal. Apply that information to yourself, and then you should make a rational decision. However, I'm in the process of trying to develop a way of integrating the extended parallel process model into that appraisal process to get at that emotional component, because humans are not rational as much as we would like them to be. So I think integrating that emotional component, because I think if we dig deeper and see some of these social norms about monogamy and sexuality are really driving that appraisal process, even though people have good understanding of something doesn't mean they're doing it.
Well, I think that's this dual model would be really a great advance in this area. But at the same time, it also seems that they actually don't have the right knowledge, right? So they say they understand, but then they actually don't understand that their partner could be exposed to Zika, and even if they're monogamous. Right?
That is correct. So there were some gaps in their knowledge regarding not only Zika and sexual transmission, but contraception in general. So some women said, oh yeah, I'm on a great method, highly effective. And I asked, and oh, I'm using withdrawal. And so there are definitely some issues in terms of their cognitive processing regarding contraception, which may be more symptomatic to underlying issues in the United States and in Florida and our contraceptive needs in sex education. Thank you.
Thank you, Erika.
Thank you.
Extreme pleasure to introduce our next candidate for the faculty position that we're considering folks for in PFRH, Erika Thompson. Erika Thompson is currently a postdoctoral fellow at the Department of Community and Family Health at the University of South Florida. She earned her doctorate there in 2015. And she also earned graduate certificates in biostatistics and in maternal and child health epidemiology. So her research, which focuses on women's decision-making about their reproductive health choices, has resulted in over 28 peer-reviewed publications, 10 of which are first authored. That's quite an accomplishment for somebody who just graduated in 2015. But as we've discovered in talking with her, the committee has learned, she's not working from a cave in USF. She's actually really involved in the community and public health. Her productivity is fueled by a depth of understanding of theories, social, cognitive, behavioral, public health theories, as well as a life course perspective. And that is that perspective and that depth of understanding she brings together with quantitative methods, how to describe the phenomena, how big the problem is or the issue is, as well as moving on to answering questions about why. Why do we see the disparities and the disconnects that are so common in women's reproductive health? So her focus has really been